This is the second part of the series of abdominal examination videos, and in this part we will discuss palpation, percussion and auscultation of the abdomen. Like inspection, we will break the palpation into 8 steps. Each step is 4 points like in palpation. Many of the points will cover both palpation and inspection, and we will mention that at its time. The first step in the 8 steps in palpation is exactly like inspection. There is 4 before you start. You have to have a warm, clean hand. You have to take proper consent from the patient to reduce yourself, ask permission for examination, and ask whether there is any painful area in the abdomen. You have to put the patient in a comfortable position with a raised head like here, and if needed you can relax the knees and put a pillow under the knees. And then you have to have a proper exposure, as we have said before. That's from the nipple line down to the mid of the thigh. And in this situation, we will just expose the groins just to keep the decency of the patient. The next 4 will be the big hitters. That would mean the main 4 items which will be performed during palpation. So the first point will be discussed now, and we will have to look for the temperature. And actually we're looking for temperature change. And what you need to do is to feel the skin and compare it to other areas. When you put the back of your hand to feel, you have to wait a little bit for convection of temperature. So you don't put it and leave it. You have to put it for probably 5 to 10 seconds. Then there will be equilibrium between the temperature of the patient's skin in your hand, and then you move it to the other area. And by comparing areas in the abdomen, you can see and watch if there is any area with increased temperature. Then we have to do superficial palpation for tendons. And what you do here is you superficially palpate the 9 areas of the abdomen that we discussed before in inspection. What I want you to do is to relax your hand on the tummy of the patient. Don't put your fingers, put your hand. So you relax your hand on the patient, and the patient will feel confident. The more you're confident, the more your patient is confident in you. And then you don't only put your hand, but you have to look to the patient's face. It's very important that during this step to look at the patient's face, because actually we're looking for the tone of the muscles and for tenderness. So you simply palpate the 9 areas. While you're looking to his eyes. If there is a pain, the pain will be evident by the grimace of his face. If the patient said he has a painful area in the abdomen, then that will be the last area to be examined. Then the next step is to do deep palpation. And like in superficial palpation, it will be exactly the same. Now the patient has pain, right? So that's pain on the palpation. That's because of distension of the abdomen. And in this kind of deep palpation, you can feel organs and masses. We will do that in more details in a minute. If there is a tenderness, just to remind you, during this examination, you will have to look to the face of the patient for signs of pain. First thing, we look for the type of tenderness. Is it generalized or localized? So if the pain is only in one area, that's localized. If it is all over the abdomen, then it will be generalized. Generalized tenderness is not a good sign. Localized tenderness is a sign of irritation of the parietal peritoneum. Actually, sometimes it's generalized because only the visceral peritoneum, the part that is irritated. When the parietal peritoneum is irritated too, then we start to have a localized tenderness. Tenderness means pain on palpation. Okay. When the parietal peritoneum is more irritated, then we have a rebound tenderness. That would mean when you press on the tummy of the patient, there is pain here, and then you keep it for a minute or so, and then you suddenly release your hand. When you release your hand suddenly, the recoil of the abdominal wall is much faster than the intestine. So the intestine will come later, then the parietal peritoneum will touch the visceral peritoneum in a sort of a flick that will be very painful to the patient, and that would mean a higher degree of peritoneal irritation. When the irritation becomes higher, then will be a cross tenderness. That would mean if the right side is tender, then when you press on the left side, you find the pain on the right side. That's cross tenderness, and that means that the irritation is so severe that the slightest displacement of fluid in the intestine or the intestine itself can irritate the parietal peritoneum. The last grade of peritoneal irritation is guarding or rigidity. Guarding is an act that is taken by the patient to protect his abdomen, is not an involuntary reflex. So guard is voluntary, while rigidity is involuntary reflex. And in this stage, you will find the abdomen completely hard to examine, doesn't yield, doesn't give away. And not in this patient, of course, but if you find this board-like rigidity, what you do is to direct the patient mind to another thing. You have to talk to the patient for a minute, so he will be withdrawing from protecting himself, and at that time when you examine, then you can have a lax abdomen. That will differentiate between guarding and rigidity. The next step is for if a mass is found. It's very simple, and it's very similar to what we said in inspection, but here we will rearrange the pies. When a mass like this one is found on palpation, then the first thing here is to determine whether it is an extra or intra-abdominal mass. And intra-abdominal masses will move with respiration. So if you put your hand away and ask the patient to take a deep breath. ممكن تاخد نفس جامد لو سمحت؟ خد نفس، خد نفس، خرج، خد نفس، خرج. As we can see, it moves down with respiration. That would mean that's connected to the diaphragm, as we have said before, and that means this is an intra-abdominal mass. Next thing to confirm that is ask the patient to raise his head, and if the mass disappeared or become less evident, that would mean this is an intra-abdominal mass. As you can see, the mass actually disappeared and decreased in size, like here, and that would mean that this is an intra-abdominal mass. Next thing is you palpate the position, and now by palpation I can confirm that it is in the left lumbar too, right? Not only here, but it extends down to here and here. And so this is the mass that we found. Now we move to judging the characters of the mass. First thing is we have to know the size of the mass, and usually we do that by measuring the long axis and short axis of the mass. If the mass is not that huge, we used to use the fingers of the patient to measure it, so you can easily say it's 2-3 fingers. This is the costal margin, and you ask the patient to put his finger, if it is a small one, to measure it in his own fingers. But actually, it's much more accurate to use that with a ruler or a measuring tape. Then you judge your shape. You judge the edge. Usually, ill-defined edges in the abdomen would indicate inflammation, not malignancy, and that has to be remembered. And then the surface the consistency by two fingers, two perpendicular lines. And then you test for the mobility. Mobility with respiration. Yeah, it's movable with respiration. And then you test for the side-to-side mobility like that. Be sure that it's mobile. If the mass is in the center, it might be an ovarian cyst or a mesenteric cyst. And in this situation, what we do is to shift the mass from one side to the other. If the mass is fully mobile, not limited, usually this is an ovarian cyst. Mesenteric cyst will move from side to side, but not along the axis of the small bowel, mesentery. Last thing is look for pulsation if the mass is pulsatile. And we have to differentiate between transmitted pulsations and expansile pulsation. Transmitted would mean that the aorta is pulsating or a large vessel is pulsating and the pulsations are transmitted. And in this situation, what you need to do is put two fingers on the pulsating area and look what happened. And look what happened. ممكن تاخد نفس وتكتبه النقطة دي. اكتبه بقى. If you look here, there is a pulsation, and when I put my fingers, actually we can see my fingers are moving up. So they move up and down. That's a transmitted pulsation. In cases of aortic aneurysm, the pulsation will be expansile. So when I put my fingers, they will move away, not up away from the aorta. If it is difficult to differentiate whether this is transmitted or expansile pulsations, what you can do is simply put the patient in nichist position. As we said before, if it is transmitted, the mass will fall off the aorta and then the pulsations will disappear. To differentiate between transmitted pulsation and expansile one, if we remember the slight pulsation that were here, when the patient is lying in the nichist position, transmitted pulsation disappear. If it is expansile, you will find that there is still pulsation on the area, because when the patient is in the nichist position, the mass which transmitted the pulsation of the aorta falls off the aorta. The next step now is to examine four organs in the abdomen. The lower border of the right lobe of the liver, the lower border of the left lobe of the liver, the lower border of the spleen, and the kidneys. To start examination for the lower border of the right lobe of the liver, we start in the right iliac fossa. You have to relax your hand on the abdomen. You do a deep palpation, and then you ask the patient to take a deep breath. While the patient is taking the deep breath, you elevate your hand up, so the border of the liver, when it is coming down with the respiration, it will hit your finger, so you can see where exactly it is. So that's exactly what I'm going to do now. I'll put my finger, relax all the hand of the abdomen, ask the patient to take a deep breath, and then I'll move it a centimeter or so every time to see where is the lower border of the right lobe of the liver. خد نفس جامد لو سمحت. قربوا. لا ما اخدش نفس زي ما اقول لك لو سمحت. خد نفس. قربوا. ما تاخدش نفس تاني لغايه لما اقول لك. خد نفس. قربوا. خد نفس. قربوا. خد نفس. قربوا. خد نفس. This is the costal margin. So as you can see, although this patient complains from portal hypertension, the right lobe of the liver is non-bowelable and probably it's shrunken. And then in the midline, we'll look for the lower border of the left lobe of the liver. We'll do exactly the same. A deep pressure. خد نفس جامد لو سمحت. خرجوا. ما تاخدش نفس غير ما اقول لك. خد نفس. خرجوا. خد نفس. خرجوا. خد نفس. خرجوا. خد نفس. خرجوا. نفس. خرجوا. ده this is the lower border of the left lobe of the liver. I felt it everywhere. This is enlarged left lobe, and this is common hypertrophy of the left lobe due to the compensatory mechanism after shrinkage of the right lobe of the liver. Then to test for the lower border of the spleen, we change direction and we go from right to left. Lower right. خد نفس. خرجوا. خد نفس. خرجوا. خد نفس. لا معلش تاني. خد نفس. خرجوا. خد نفس. خرجوا. خد نفس. خرجوا. خد نفس. And this is it. I can feel it. Again, let's see that again. خد نفس. Yeah. This is the lower border of the spleen. If the spleen is just palpable and you want to confirm the enlargement, what you need to do is a bimanual examination of the spleen. And to do so, you need to put the patient in the right lateral position, relax your hand on the costal margin, then you use your hand, ask the patient to take a deep breath. خد نفس لو سمحت. خرجوا. تاني. تاني. Until you hit the costal margin. If you can feel it, that would mean that if it is palpable here, that means it's enlarged. Actually, if you can feel it, the spleen is usually 3 times its normal size. When we find a mass in this area, we will have to look for the characters of the mass, as we said before. And this mass is actually continuous below the costal margin. We cannot insinuate our hand between the costal margin and the mass. Such mass is usually a splenic enlargement. The border here is quite rounded and well defined. The surface is smooth, but if you think this is a spleen, you have to confirm that it's moving with respiration, as we said before. خد نفس لو سمحت. Yes, it's moving with respiration. And you look for the splenic notch. You go along the upper border, and as we can feel here, there is a notch that will confirm that this is a splenic enlargement. Now to test for the kidneys. And you can feel the kidney in very thin persons. You can feel the lower border of the right kidney of the person is very thin. And when we try to test for the kidneys and renal masses, we do it by bimanual examination. So put a right hand anterior and your left hand posterior, and both by trying to see both hands at the same time, you try to feel if there is a mass in the area. If you find a mass, and to confirm that this is a kidney, what we do is ballotment. And by ballotment, we do the following. Relax your right hand on the abdomen with slight pressure. You push with your left hand up, and in this situation, if this is the kidney will rise up, hit your right hand and go back down. That's called ballotment, and that occurs only in renal masses. The next step would be exactly like an inspection to confirm what we found in the inspection, and this is 4 on the back. So first you have to look for spine tenderness, and what you have to do is you test tenderness along the spine. I'm looking to the patient face from the side to be sure that it's not painful. Then you have to look for tenderness on the spinal muscles. This is the paraspinal area, muscles. Actually in this patient, there is some tenderness here. You can see the patient is wasted on the back. You see this is malnutrition, of course, because actually you can see the ribs, not the muscles, on the paraspinal area. Next you have to look for sinuses and masses. So you palpate the rest of the back. And then you look for tenderness in the renal angle, and the renal angle is the angle between the last rib and the paraspinal muscles here. So this is the renal angle, and you look for tenderness. I'm looking at his face from the side to be sure that the area is not tender. tenderness occurs in renal masses. The next step now is to confirm few of the things that we found on inspection. Now you can touch the sternal angle to see whether it's obtuse like here. You can touch any scars in the abdomen to see and feel whether the healing is fine and if there is any impulse on cuffing inside. You can touch to see the direction of flow in dilated vein around the umbilicus. And as we said yesterday, if the portal pressure is high and the portosystemic collaterals are open, you can find the caput medusae. You will find veins which are dilated and tortuous and going away from the umbilicus. And to be sure that the direction of flow is away from the umbilicus, what we do is, when you find a vein like that, there is a small vein here, and I'm not sure whether this is clear to you or not, and what you do is you put two fingers and empty it. And then you remove first the finger which is away and see if the vein is going to fill. And then you do that, empty the vein, remove the finger from within, not from without. So if the filling is from the umbilicus outward, that's a portal hypertension. If it is filling toward the umbilicus, mostly that will be venar caval obstruction. Then you can test for impulses. So if you found on inspection impulse on cuffing on the umbilicus, now you can put your hand and ask the patient to cough. Come in. The last step in palpation is exactly like inspection. To complete our exam, we need to look and palpate the legs for edema. By pressure on the chin of the tibia, keep your finger for 10 to 15 seconds and look for edema. In both sides. Next point is to feel for the testis and the groins. The testis for the testicular sensation, masses, and then you put your hand and ask the patient to cough. For impulse on cuffing, again. Next you have to look for the left supraclavicular lymph node, the vertical lymph node, and be sure to palpate it for the Troisier sign, enlargement in cases of advanced GI malignancy. And what you need to do is a rolling movement. When you look for the lymph nodes, you have to do a rolling movement. And the last step to complete our exam is to do a perirectal examination, which we are not going to do in public to keep the decency of the patient here. Now we'll move to percussion of the abdomen, and that will comprise 2 steps. Each step comprises 4 points. First, we will percuss for a solid mass or a solid organ. If you find the mass, then we can percuss the mass. The small mass, if it is here, usually will become dull if it is a solid. Or you can find a band of resonance. That will happen in retroperitoneal masses. You start by a dull mass, and then you find resonance because the colon is crossing here, and then you find it dull again. So even by that you can differentiate retroperitoneal from intraperitoneal masses. Then we're going to percuss the liver. The lower border of the liver by light percussion is regional till the costal margin, so it's shrunken. And then we will percuss the upper border of the right lobe of the liver, and we start in the mid-clavicular from the second intercostal space Now it's becoming more dull. To be sure that this is the upper border of the liver, we'll ask the patient to take a deep breath. First we percuss it. خد نفس جامد. And now it's resonant. So that is called tidal percussion, and that will confirm the liver of the upper border of the liver. Normally it will be in the fifth. As you can see here, it's shrunken slow. And we can measure the span of the liver here. Usually it's probably double that size. Percussion of the spleen for enlargement is percussion in the ninth intercostal space from the posterior axillary line forward. If the mass is beyond the mid-clavicular line, that would mean that it is enlarged. So we have to define where the ninth. To find the ninth intercostal space, we start on the second intercostal space, which is very close to the sternal angle. Third, fourth, fifth, sixth, seventh, eighth, ninth. So that's the ninth. Start in the posterior axillary line. Anterior axillary. As you can see, it's still dull. Still dull even in the mid-clavicular, and that would mean that there is a splenic enlargement. The last step in percussion for a solid mass or organ is percussion of the renal angle. Usually the renal angle is resonant because the colon passes there. If it is not resonant, that would mean that there is a mass inside. Next step is to have four fluid. Now we're looking for intra-abdominal fluid. And first of all, we start by trying to find dullness in the flanks. We start at the level of the umbilicus and goes to the lumbar areas and then to the flanks. Now you can see the tone has changed. That's dullness in the flanks. To be sure that this is not a dullness of a mass, you have to do a shifting dullness test. Fluid shift inside the abdomen when the abdomen moves in different directions, so that's exactly what we're going to do. At the umbilical level, we start for percussion. When it is dull, you keep your finger in, ask the patient to roll to the other side. نام على جنبك الشمال لو سمحت. على جنبك شوية. And you leave it for 10 seconds. Maybe 20 if you like. Give the time for the fluid to shift inside. And then you percuss it, it's resonant. That confirms that this is a fluid and the fluid has shifted. To reconfirm, we'll ask the patient to come back to his back. ارجع ظهرك تاني لو سمحت. Leave it for another 20 seconds for the fluid to settle down. And then you percuss it. Now it's done again. If the intra-abdominal fluid is massive, like intense ascites for example, the fluid will not shift because it fills all the compartment of the abdomen, and what we need to confirm the presence of fluid is to do a fluid thrill. You will ask your assistant to put his ulnar side of the arm in the mid part and press on the fat to prevent transmission of thrill through the fat. You relax your right hand on one side and then you flick on one side. What you will feel is a thrill of fluid, a wave of fluid hitting your hand, and this is what we will call fluid thrill. If the amount of fluid is minimal and you can feel it by percussion or shifting dullness, usually if the amount is 500 ml or below, then we can do that by percussion in a knee chest position. It's very simple. What you can do is to give the patient 20 seconds for the fluid to become at the bottom of the abdomen. You put your hand and you percuss it for dullness. Actually, it's very dull now, as you can see. This is not minimal, of course, but if there is a minimal fluid, it will be dull exactly like that. The last stage in examination of the abdomen is auscultation. And like every stage before, it comprises steps, and each step comprises 4 points. Actually, in auscultation, there is only one step with 4 points. First of all, we're going to auscultate for peristalsis of the abdomen. In the periumbilical area, you need to wait for a little bit. Actually, sometimes in normal individuals, it takes 3 to 6 minutes to feel a peristaltic movement. So you have to wait a little bit to listen carefully. If there is tinkling bowel sound, that means distended bowel sound, that's a sign of intestinal obstruction. If you find a mass, especially if it is pulsatile, you need to auscultate over the mass for bruit. If the spleen or liver is enlarged, you need to auscultate the intercostal spaces for rub with inspiration. That would indicate inflammation in the capsule of the liver or the spleen. Then you need to auscultate for the aorta and the renal arteries. This will conclude our examination of the abdomen. So to summarize palpation, there is 4 before you start: caring for the hand, consent of the patient, proper positioning, and proper exposure of the patient. There is 4 big headers: testing for temperature changes in the abdomen, superficial palpation for tenderness, deep palpation for organs, deep palpation for masses. 4, if a tenderness is found, to see if it is a localized or generalized tenderness, if there is a rebound tenderness, cross tenderness, guarding, or rigidity. 4, if a mass is found, determine whether it's extra or intra-abdominal mass, describe the position, see the characters of the mass, size, shape, edge, consistency, and mobility, and test for pulsations. Palpate for organs: right lobe of the liver, left lobe of the liver, lower border of the spleen, and kidneys. Then there is 4 on the back: spine for tenderness, paraspinal palpation for tenderness, palpation for sinuses and masses, palpation for renal angle for tenderness. And there is 4 to confirm from inspection: confirm the sternal angle, the scars, direction of flow in the dilated veins, and impulses on cuffing in the umbilicus. And lastly, to complete our examinations, 4 points to remember: test legs for edema, palpate scrotum and hernial orifices, palpate left supraclavicular lymph node for enlargement, and do a PR examination. Now to conclude percussion, we will percuss for solid organs and masses, 4 of them: the mass, the liver and liver span, the spleen for the upper border, and the renal angle for resonance. 4 tests for fluid in the abdomen, dullness in the flanks, shifting dullness, testing for minimal ascites in the knee chest position, and fluid thrill intense ascites. And now to conclude auscultation, only 4 remains. Auscultate for peristalsis, auscultate over lumps for bruit, auscultate abdominal aorta and renal arteries, auscultate over the intercostal space in cases of enlargement of the liver or spleen for